Thanks to everyone who's joining us. We'll just give it one more minute because I can see there's still numbers rising. Okay, so I think we'll get going because we have quite a packed and exciting program this afternoon. So I'm Cate Bailey. I'm an older adult psychiatrist working in Newham. And I'm really pleased and grateful to Elena for asking me to chair this afternoon's Barts program. It's quite a bold title, How Can Trauma-Informed Approaches Innovate Practice and Sustain the Workforce? But I think it's justifiably bold. And for me personally, although trauma-informed care is something that I've kind of come to more in the last couple of years, it's certainly been something that's really shaped my practice and is one of the most important things that I've learnt in recent times and continue to learn about through teaching, including medical students and teaching alongside people with lived experience. The first thing, though, to think about is that we're going to be talking about something potentially quite difficult. We're talking about trauma, and that's something that we as individuals and we as society would rather not think about and have various defense mechanisms to help us not to think about that. And indeed, it feels like a difficult thing to ask of a group of staff who are perhaps more traumatized than ever, and of course bring our own trauma to work, perhaps even the thing that stimulated us to follow a caring profession in the first place. But Judith Herman is helpful here in thinking about how we approach trauma. She's the author of Trauma and Recovery, and she writes that the conflict between the will to deny horrible events and the will to proclaim them aloud is the central dialectic of psychological trauma. And that's something that operates in us as individuals and in society, but it also operates in the way that psychiatry has responded to trauma over the years. And if you look back over kind of how the profession has responded, there will be moments where it seems that trauma will be proclaimed and spoken about, only to quickly be silenced and denied and disbelieved. But I think we're at a time now where more than ever, the survivors of trauma, including those who've experienced trauma in our own services, as well as the kind of neuroscience and physiological research, is moving ahead very, very quickly. And we know more than ever about the effect of trauma on the mind and the body. And as people who work with the mind and the body, or embodied minds, it's so, so important. And I think that we have an obligation, or at least a responsibility, to educate ourselves as much as we can, as well as an opportunity to use the knowledge that is coming in recent years to help our patients and indeed ourselves. We're just going to go back a few years, though, to the ACEs study, which is useful to kind of think about. By no means the first time that adverse childhood experiences were thought about. Indeed, the term adverse childhood experiences was coined by Bowlby. But it was 1998 when Robert Ander and Vince Veliti kind of conceived of these operationalized ideas about adverse childhood experiences and asked almost 10,000 people about their experiences, and found quite strikingly that many, many people had experienced childhood adversity. But not only that, that there was a graded dose-response relationship between childhood adversity and later life health outcomes. That's been replicated and followed up in many, many studies across the world and across different populations, and to the point where it's been identified that having more than 6 of these ACEs is associated with a 20 years reduced life expectancy. But really, really important that we think about what trauma can be beyond those original ACEs. They were very compelling in what they were able to show us about the link between childhood adversity and physical health outcomes. But trauma can be so much more than that. ACEs have been sort of critiqued appropriately for being quite white and Eurocentric. And it's so important that we understand that there are many, many other types of trauma that are not captured in that study. Things of migration, torture, caring responsibilities, prejudice, and other forms of discrimination and racism. But also there's a need to understand that it's not only the trauma in and of itself, it's also about how a family or a society responds that dictates how someone might grow and change from that. But what about mental health services? Why do we need to be thinking about trauma? Well, going back to ACEs, as limited as they are, it has been found that more than 4 ACEs is associated with a 30 times higher risk of lifetime suicide attempt. So if we're thinking about who we're seeing in A&E, or even if we're interested in suicide prevention, we need to be thinking about childhood adversity. And studies have been done in various settings, but it seems that probably between 70 and 90%, and perhaps even more, of people who attend adult mental health services have a history of trauma. But importantly, it's often not recorded. So this study from Ireland showed that about half of the experiences of trauma are actually recorded in people's notes. And there's very many reasons for that. And it may be quite appropriate that we haven't asked about trauma, especially if we're having limited brief contact with people. But what it does tell us is that there are traumas that people have experienced in people that we see that we will never ever know about. So trauma-informed care becomes even more important. So how does childhood adversity and trauma linked to poor health? Well, the first thing that people often think of is the link between childhood adversity and coping strategies. And that's certainly part of the story, but it's not the whole story. So when prospective studies have been done on the relationship between adverse childhood experiences and heart disease or lung cancer, smoking explains part of the effect, but not the whole effect. There are links, of course, between ACEs and other social determinants of health, and they're not distributed equally, but there are also neurobiological, physiological, and genetic pathways that we are learning more about all the time. Without going into too much detail, and I'd encourage you to read more about this because we don't have time to go into it too much today, but essentially chronic stress is damaging, and it's particularly damaging to developing bodies and minds. Chronically elevated cortisol, we know, leads to hyperglycemia and inflammation, which is of course linked to many, many adult diseases, from depression to cancer to ischemic heart disease. But also on the developing brain, high levels of cortisol can have a particular effect on areas like the hippocampus. And this has been shown across a number of different studies in terms of a dose-response relationship with shortening of telomeres or inflammatory markers, and indeed even epigenetic effects. And racial discrimination as a form of trauma has also been associated with all of these preclinical indicators of disease, so increased allostatic load, shorter telomere length, and so on. And again, we don't have time to go into all of this today, but there is overwhelming evidence that childhood trauma affects neural connectivity. But really, really importantly, what we need to understand from this, apart from educating ourselves about the various changes that can happen, is to understand that a lot of the responses that happen in a child's brain are adaptive to a particular situation. So if we take the example of increased amygdala volume and hypersensitivity to threat in people who are growing up in an unpredictable and dangerous environment, that's actually quite protective in that time. It means people can pick up cues before the danger's even there. They can get themselves to a safety. Where that becomes a problem potentially, though, is later down the line, where there maybe is a situation where they need to be able to trust somebody, perhaps even in a healthcare situation. So how does trauma potentially affect interaction with health services? Or perhaps we should actually reframe this as, how do health services respond to people with trauma? Which could be summarized in kind of not very well, I suppose. But if we think about how it might affect people's trust or the way that they engage with health services, people might attend frequently, they might use coping measures and symptom control, they might never attend or not attend screening, because screening and in and of itself can be re-traumatizing and potentially invasive. People might leave without treatment because actually there's a lot of evidence to show that inpatient environments can be re-traumatizing and difficult for people who've experienced trauma. People might have chronic conditions and multimorbidity and dual diagnoses, and by virtue of those, they may then not receive any of the help for any of those diagnoses, because our health system is not really set up to care for people who have complex needs. And they end up with what's described by Julian Tudor Hart as the inverse care law, which is this relationship between the actual need for healthcare and how it's utilised. And then there's the uneasy facts of why healthcare in and of itself might be re-traumatizing. And this is really hard, but so important for us to think about. When people encounter healthcare services, there is an inherent power imbalance. There's often invasive procedures, there's removal of clothing, physical touch, and this occurs across settings, not just in mental health. There's vulnerability, there's potentially blaming and shaming, there's lack of privacy, loss of control, of freedom, of choice. And there's underpins all of this is an assumption of trust in authority figures and institutions, which for many individuals and many groups isn't there. There's also a loss of epistemic authority, and by that I mean that people, particularly women and Black and brown people, will lose the credibility in what they describe experiencing in their own body. And we see that in how people's pain is treated or not treated, or how people are referred on for specialist care after a heart attack. And then there's the kind of sharp end of re-traumatization, restraints, observations, police responses to mental health crises. And that leaves us in a difficult position, and it seems a little bit hopeless perhaps, but I think that trauma-informed care really offers us an opportunity to acknowledge that trauma is very, very common, and to think about how we might adapt our services to respond to this. I would invite you today to think about what you're hearing from people with lived experience and people who are trying to work in this way, and perhaps you're already trying to work in this way, and hopefully this will be empowering and inspiring for you as well. So I'd invite you to think about what your service might look like if we really were trauma-informed. Imagine that and think perhaps what we can do together to try and create that reality. Just a few kind of housekeeping rules, which I neglected to mention earlier, is that we are being recorded today. Some of you might have identified that already, and that you're welcome to kind of comment in the chat as we go through. But if you've got a specific question that you would like our speakers to answer, please put it in the Q&A, because that's where we're going to take our questions from. We're going to have a break for questions at the end of each block, and then a break for tea and coffee at about 3. So I'm just going to finish sharing my screen now, and I will be handing over to Marion. So just to introduce Marion, Dr. Marion Bates, who's a consultant clinical psychologist, co-lead for complex trauma in Newham and co-lead psychological services in Hackney. Marion and her counterparts in other boroughs have been working with colleagues across professions in ELFT to provide trauma-informed care training and strategic thinking since 2018, alongside work as specialist psychologists assessing, treating and supervising trauma interventions. So I'll hand over to Marion now.
Hi everybody, nice to meet you. I'm trying to share I'm so sorry, there's a menu that's covering the bit where I can share the slides as a slideshow. Here we go. Sorry about this, everyone. Right. Okay. So I'm going to present to you some of the slides that we use when we're training staff. So a lot of the work that we're going to talk about today is about how we've presented trauma-informed care across East London Foundation Trust and other providers who work in East London. So first of all, Kate's done a lovely introduction. So some of this will be a bit of a repeat, but basically trauma-informed care is strengths-based service delivery model, and it's grounded in an understanding and responsiveness to trauma. And it really emphasises the different types of safety that we can offer to service users and to our staff. So that's physical, psychological and emotional safety. And the way that trauma-informed care does all of this is by promoting environments of healing and recovery, as opposed to sort of practices and services that may inadvertently re-traumatize. And I think, as Kate said at the beginning, you know, hopefully none of us went into caring professions in order to deliberately re-traumatize, but sometimes it happens alongside what we're doing. Why is it important to do trauma-informed care and to adopt this approach? Well, it's really very much part of the way the National Health Service is thinking about policies and about how we change our models of care. And it's in the long-term plan here, which I'm copying in. So that's something that you can look at outside of this. One of the common misconceptions about trauma-informed care is that it is us teaching people how to work with trauma. We're very much, want to stress that it is not teaching people how to do psychotherapy with people who've experienced trauma or who might meet criteria for a diagnosis of post-traumatic stress disorder. It is not a specialist treatment that somebody's going to be able to offer. And we don't have a manual for it, although there are lots and lots of resources online and there are books. What trauma-informed care is really is a philosophy of practice. It is a lot of what you're doing already, but different. And it's something that is not a destination. It's not a finite way of operating. It's something that changes and is flexible as we move through time and different things that happen in our lives. So there are different types of trauma. This is something that we kind of present to everybody. You'll be aware of all of these things, but sometimes, things that are not the traditional things, like a car crash or being in a war. There are often many things that happen across somebody's lifespan, and they can be small developmental traumas that at small events. So we can include bullying, discrimination, we can include different types of abuse, war, as I say, gender, sexuality and racial discrimination. And all of these things here can lead to causing trauma and symptoms of trauma in an individual and in groups. And of course, we're not saying that everybody who experiences one of these things will respond in a way that is troubling and problematic for them. They might not meet criteria for service use or for any diagnosis that you might be giving them, but it's nevertheless significant that these things are causing people's difficulties when they present to services. It's important to study this because the effects of trauma can be so impactful, and I think, as Cate outlined with the physical health problems that you will all see, you'll see that people have much higher rates of trauma in their past, and these affect their physical manifestations. So trauma can impair memory, concentration, the ability to encode new information, and the ability to focus on what you might be talking to them about, or what they might need to focus on in order to move their lives forward. As Cate said, trauma is correlated with a huge number of physical health conditions, and often things that we can't quite pinpoint, that are sort of like more autoimmune or functional disorders. Trauma can have a massive impact on our ability to trust and cope and to form healthy relationships with people. And that is a huge part of the work that we do. If we have healthy relationships and can build healthy relationships, we can move forward in recovery. Trauma disrupts the ability to identify emotions, to understand emotions, and the ability to regulate our emotions, to tolerate distress in the moment. And it can have a huge impact on an ability to distinguish what might be safe or unsafe. So if you're examining a patient, for example, what you think may be safe or should be safe may not be at all safe for the person concerned. And trauma shapes our belief about ourselves. It also has a huge impact on our ability to hope and our ability to look forward to the prospect of change and one's outlook on life. One of the, oh, it's done it again. So sorry, my fonts are all a bit skew-whiff here. One of the ways that we think about how people present to us is this sort of model of trauma. So when we're presented with a threat, we may respond in one of these 5 ways. So we may have a desire to run away, so to flee, and you'll all know about this already, the fight, flight and freeze options, but there's also flop and friend. And if you're thinking about people that you work with in clinic, or indeed staff members and colleagues, you can identify maybe some of these responses in how they behave and how we behave ourselves. So for example, if we're presented with a threat, we might have an urge to run away. Now in our modern day, the flight response can manifest in, for example, avoiding using substances, an urge to end our lives. And these are not sort of the traditional fight or flight, sort of attacking a woolly mammoth in terms of evolutionary psychology, but they are very often responses to a past trauma. So when you see a response like this and it seems out of the ordinary, you can be fairly sure it's not because it's something to do with you, but because of something that's been triggered in somebody's past. So we have a fight response, which we see in waiting rooms and reception areas very often, this sort of aggression that seems far out of the ordinary, out of context rather, for what we would expect for the situation. The freeze response, I do it quite often when I've got many emails and hundreds of meetings to go to. I might feel like I'm doing a lot of work, but I'm actually not achieving anything. So I'm on a sort of hamster wheel. And that's kind of freeze response that you might see in yourselves or in colleagues. And you will see it in clients. People are really unable to move forward, unable to think about what they might need to work on, and kind of literally freezing. Flop is a kind of more dissociative, sort of giving up, hopelessness, extreme sort of depression response, often arises from shame. And the friend response we might see in somebody who's traditionally it's Stockholm syndrome, when people fall in love with their kidnappers, but it might be in the sort of help-seeking behaviour and attaching to staff, and that may have its sort of background in a response to how they've been brought up and previous attachment styles. So when we're talking about trauma-informed care, just moving on from that, we're talking about the 4 R's of TIC. Okay, so trauma-informed care, this is what we hang all of our training on. First of all, we at trauma-informed organisations and clinicians need to realise the widespread impact of trauma and understanding potential paths to recovery. So we realise that trauma has a huge impact on pretty much every manifestation that you might see in your clinic. We recognise the signs and symptoms of trauma, so we might recognise some of those 5 F's in the people who come to see us. We aim to respond by fully integrating the knowledge about trauma into every aspect of our care. So it's not just what we do in the clinic room, it's not just what we do in a hospital ward, it's how our policies, procedures, and our environments and contexts are shaped in order to respond in a trauma-informed way. And the aim of all of the R's is to resist the urge to re-traumatize. So it's this indirect, inadvertent re-traumatization that happens. So for example, when people are having to be restrained, for example, for their own good or to protect their safety, this can often be extremely traumatic for somebody who's been abused, somebody who's been held down in the past and unable to move. So it's that freeze response that might then provoke a fight response in somebody, and then maybe people are then further re-traumatized. So it's well documented, the kind of re-traumatization that healthcare settings do inadvertently. Okay, so these are some examples. Imagine having to continually retell your story every single time you meet a professional. Yeah? This is something that service users tell us over and over again. Please, I don't want to have to retell my story. It's traumatizing. Being treated as a number, so like at the butcher counter in Sainsbury's, perhaps. Procedures that require taking clothes off that maybe it's not essential to do. Being seen as a label. Now I know that we don't do this deliberately, but sometimes I've heard people in the past talking about borderlines, autistic people, autists, schizophrenics. We're more than our label. Yeah. Having no choice in service or treatment. no opportunity to give feedback about their experience with the service. So these are things that people have said are re-traumatizing for them, and of course they're things that we're trying to change. So we're talking about these kind of things that will trigger past attachment experiences and past abuse experiences. Okay, so you can see that for yourself. What we then pin are kind of foundations of trauma-informed care and healthcare, not healthcare, as I've put up there. We're talking about principles of trauma-informed care, which are providing safety, choice, collaboration, trustworthiness, and empowerment. And I'm going to just whiz through these because we don't have much time for my little bit here. I want to move on to everybody else. So we're talking really about creating that environment that really allows people to flourish, to feel safe, and that will make our jobs easier and make our jobs more, make our relationships more fulfilling. So these are just some of the examples. Now, I think I'm going to have to go a bit faster now. I'm so sorry, everybody. I want to get everything in. So some of these things are examples of how we might improve our trustworthy and transparency. So communicating what we are, not offering too much, being realistic about timeframes, doing what we say we will, which is actually, it's obvious, isn't it? But it's so hard to do sometimes. One of the huge aspects of trauma-informed care has been service user involvement, which we're modelling today with service users who've co-produced and developed our training packages with us. So there's a huge power in peer support and promoting sustainable and continued sort of healing and growth that isn't just sitting in a one-to-one clinic. It's support from other people who've been through similar experiences, which is really powerful. We're talking about cultural, historical and gender issues, keeping in mind that people have different needs and preferences, that it's not just about a group of people. So people talk about, yes, well, I need a particular training in working with people from a Muslim background, for example. Well, what a trauma-informed way would be to ask the individual what that means to them. And we're not making assumptions that people might have a very strict view of something related to culture or spirituality, and we're asking people. We're giving people clear processes for feedback, and we're responding to feedback, and we're using it. So we're not just having a "you said we did" board, which we do. We're making sure that we do the "we did" part of it, and that we're feeding back, and that service users are given are empowered to actually make changes themselves as well. So to be involved with us making changes. Some of the things that we use to help people. So on wards, we've introduced the window of tolerance, which makes sure that we have an optimum. We widen the. Sorry, some messages coming in on my phone and distracting me. We're talking about making sure that somebody's in a particular state to be able to respond to what we're wanting to provide to them. So if somebody's agitated, if somebody's in one of the 5F positions, they're not going to be able to take in information. So we're trying to expand that window of tolerance so that somebody's in a comfortable position to take in information. We want to make sure that there is screening for experiences of trauma when we're assessing people at the very beginning of our involvement with somebody. And we're making sure that's done in a non-traumatizing way, so that we're not exposing people to retelling their story without being in a safe environment. So all of these things are great, and they work at an individual level and in individual teams, but none of trauma-informed care can really be lasting without a trauma-informed organisation. And one of the things that we're really, really keen on is a sort of bottom-up approach to trauma-informed care, but also a top-down approach. So we're looking at making sure that our organisations are committed to changing practices, to a sort of flexible approach to changing the culture of an entire organisation. We want to know that staff at all levels in all roles have some understanding to a greater or lesser degree of the impact of trauma on the things that happen to our service users. So some of the things that we're suggesting is that sort of, for example, in ELFT, the Trust Board has a trauma-informed approach sort of training session. So that not that it's like a huge program of things that people have to learn, but so it's some sort of awareness. We're looking at QI and audit processes, and really an organisational roadmap so that we have a direction in which we're going. And all of this is co-produced and informed by service users and by a range of service users who are able to have input at different levels according to their own recovery journeys. So it's difficult for the service users who support us to have to come and talk about trauma all the time. So we want to offer as much support as possible. We're talking about a whole training and development staff support programme, an approach to trauma screening, which, as I said before, is sort of early on in our relationship with service users, and it's respectful. We're talking about reviewing policies, procedures and environment. So I'm very keen on taking glass screens away from reception areas because sometimes it's impossible to hear anything, and that often triggers a kind of fight and flight response in people who are coming into our services. We also need to support our admin staff who are often not trained in mental health approaches, but are probably the people who have the most contact with service users and clients. So we want to be able to have a trauma-informed and compassionate approach to supporting our staff at all levels. There's a huge raft of national and international sort of input and support research and policy development around trauma-informed care, and some of these are listed here. In the NHS, we have the long-term plan, we have ELFT strategy document and the psychological professions document. We're talking about making sure that we're not just paying lip service to the recommendations in these policies, but we're building a truly sustainable and trauma-informed organisation at all levels. So I'd like to just end there and hand you back to Cate. Sorry, I ran over a few minutes.
Thanks very much, Marion. That was brilliant. So we'll move quickly on to Mina Hady and Dr. Elena Alexandru, who are going to be talking about community mental health transformation and trauma-informed practice, the story so far. So Mina is a writer, trainer and researcher. Using her lived experience of accessing mental health services, she's delivered training for staff across East London and has written about how trauma presents in marginalised groups. She's unashamedly progressive and inclusive in her views and hopes to change services for the better through co-production and collaboration. And Elena is a clinical psychologist and complex trauma lead for the Borough of London City and Hackney. Alongside her trauma lead counterparts in Newham, Tower Hamlets and colleagues in Luton and Beds, she's worked to advance understanding of adverse childhood experiences, trauma-informed approaches and practice of trauma therapy interventions. And she has particular expertise and interest in working with dissociation, survivors of human rights violations, and using narrative exposure therapy and EMDR. And she's also holds a consultant post in Oxford Health, managing a psychology service for NHS employees. And she's a founding member of the ACES Hub, which we will provide a link to after this session. So I'll hand over to Mina and Elena now.
Thanks so much, Cate. Thanks. I'm just going to share my screen.
Thanks, Mina. I think with all of this that we're saying this afternoon, and as others, as Cate and Marion have already said, is we really just want to invite a dialogue about this subject, which, if it's not coming across, we're clearly all really passionate about. And, you know, you might be interested in it, and you might be here because of that. You might be here because, you know, and you might be agreeing with some things we're saying. You might be disagreeing with some things that we're saying. And it's just to kind of notice all of that. And whenever we're talking about trauma and adversity, there's usually an impact, and that impact we usually notice in the body. So it's just to kind of, you know, because we would love to have a bit more dialogue with you, but because of this format, it's not as possible. So but you can kind of have that dialogue with yourself. So you might be noticing you're, switching off a bit. You might be noticing you're tuning in a bit more. You might be noticing that frustration comes up or anything like that, just to kind of, to sort of be with that and be noticing that, I suppose, as we're continuing the afternoon. Okay, we're going to talk to you specifically about the community mental health transformation work that we've done so far and how we've incorporated trauma-informed care into that. And lots of these things have been said already, but we know, why, and one of the other reasons we think ACEs is important is that we know that actually the majority of mental health emotional difficulties begin in childhood. So, we're really particularly interested in ACEs, and they've been spoken about already, so I don't need to say more about that. And the ambition of the transformation programme really is one where care is organised around primary care networks, with the idea of sort of allowing GPs to focus on specific population needs, to be responsive, to offer something more holistic, and to have the kind of whole network of care, whether that's social care providers, whether that's voluntary sector providers, and with a specific remit also to address health and social inequalities. So you can see that hopefully that trauma-informed ways of working lend themselves very well to this, and that's why it's kind of central to the transformation programme and central to the long-term plan.
Okay, so over to me. So there's been kind of a sort of definition of what trauma-informed care is already, but another really good way of looking at it is thinking about where the focus is. So we're aware that, the question that is not usually directly asked, but is kind of implied, is what is wrong with you? So, what is your disorder? What is your illness? And that kind of puts this onus on the service user. And I know this personally, having a diagnosis of borderline personality disorder, it sounds really negative in those terms. And actually, I don't think it needs to be that way. I think there's a way we can reframe it. So instead of thinking what is wrong with you, we instead ask a different question, which is what happened to you? What went on in your childhood? What went on in your developing years that led to you reacting to certain things in a certain way? And I think that distinction is absolutely crucial. Another really good way of thinking about it is in terms of like this graphic. I find very, very helpful for this, because often the service user is seen as kind of the problem, and that's something that's internalized. There's this sense of there's something wrong with me, and I can personally attest to that, because when you hear words like personality disorder, it automatically has really negative connotations. But I think if we look at the problem from elsewhere, it's a bit more compassionate, because it means that, the problem is coming from external sources, and the way that you are reacting is a way of demonstrating that you're suffering and that you're reacting to what has happened to you. And I think that distinction is really, really important. Back to Elena.
So this is to give you a kind of flavour of what the offer is, that we've given to the neighbourhoods around trauma-informed care, and what the vision is as well. So this kind of incorporates both aspects. So we've been in a position to be able to offer a training day to all the primary care networks across the 3 East London boroughs. And we do have work going on in Newton and Beds, although it is not specifically transformation work as well. So we've trained sort of hundreds of people actually now within our services, which is great. And I think because we have had to do this work online because of COVID, we actually have been able to reach out to more of our acute healthcare, social care and voluntary sector partners who maybe wouldn't have been able to access this otherwise, with all of the kind of competing demands and having to travel. So I think that's been very valuable, actually. And essentially what we do is some of the elements of the teaching you've seen already is we teach on the neurobiology of trauma. We use some sort of composite case examples of what happens to people kind of in the system, how we might respond to them in more trauma-informed ways, using sort of facilitated small group discussions around some of the key concepts and principles. And we end on some kind of action plans, which ask people to think about their own well-being and something that's kind of manageable for them to do to change, and also what they might be able to do from a more personal or team practice in a kind of professional capacity. We then, if people are particularly passionate and interested, we invite people to receive some ongoing support in the form of kind of supervision, reflective practice, a bit of further teaching, and also helping to support the shaping of sort of local trauma-informed projects. So the sorts of things that might mean is, you know, a team introducing a trauma screening tool to their service, for example, and how they might do that, or a team having a kind of protocol on how they manage disclosures when people talk about trauma, or thinking about a particular policy that they might want to change, or having permission to pull other people up in the team in a compassionate way when they might use language that is not so trauma informed and doesn't sort of come from a compassionate stance. There's some ideas about some potential, what a trauma-informed project looks like. Because I think one of the things we've really noticed is that unless we really operationalise what we mean by trauma-informed approaches, it can mean many different things and leads to many different approaches. Nothing wrong with that necessarily, as long as the kind of values base, the principles underneath the work are carried through. The other bits on here are, you know, we would really love to sort of develop more at the sort of trauma-informed leadership end of things, and you know, it would be great if we could also have sort of online resources and ways that people can access this information much more easily. And of course we can collaborate with other organisations for that, because there are lots of pockets of trauma-informed work happening, lots in London, but kind of lots nationally, lots in the north of England, where this work in the UK really kind of started to grow. And with all of this, there's a kind of commitment as a principle to doing things in a co-produced way. And so that takes longer, but that's a very important aspect of this. And Mina's going to speak a bit more about what that's been like for her to be part of that.
Thanks, Elena. Yeah, I mean, I've been co-delivering trauma-informed care for the past year or so, and I've probably co-delivered at least 30 or 40 of them. Probably, like, that's just an estimate, maybe more. And what I found is that it has been a real journey for me in terms of you know, various aspects of my own therapeutic journey. So, you know, I am a service user. I have been using services for about 10 years now. And, you know, I have been able to see where it's been trauma-informed and where it hasn't. So being able to speak about it and for my lived experience to be given a sense of value and like it matters is really validating, and can and is like a key part of you know, the principles of trauma-informed care, things like empowerment, voice and choice and collaboration, because this is something that we worked on together. The case study is something that we kind of came up with, the questions, and various bits of information that I gave, like examples of what trauma-informed care looks like, as well as examples of what trauma-uninformed care looks like. So being able to be an active part in this, not just a kind of tokenistic kind of tick box exercise, but rather like my involvement from the very beginning was really important to me, because I definitely had a lot of strengths in that. And I think that's a big part of whether you're receiving therapy or you're working professionally on this, but you really have to lean into your strengths. And I originally I did a law degree, so I have some familiarity with things like the Equality Act and protected characteristics. And so there was a big kind of emphasis when I was going through and I was reviewing the material about really making sure that there's something in there about human rights and the importance of autonomy when it comes to patients, and really being able to like have a say in the care that you're given, because I'm someone who's familiar with like the medical side of the law. And so it's really, really important that I was able to bring those things. So it wasn't just my lived experience of accessing services. That's one part of it, but it's also about how I could professionally grow and develop as well. I found, one of the things that was really great about it was that I was co-facilitating the training itself. So then when we went into breakout rooms to discuss certain things, I will admit sometimes people are a bit shy or hesitant to talk, and I am really good at like, poking them and getting them to do, really engage. And I think sometimes I think it helps to have someone who isn't a clinical professional per se, because it can be a bit restrictive maybe if you want to speak candidly about the problems within the system. And I found that when I prodded people a bit and got people to think about it, they really kind of opened up and spoke about a lot of the struggles they may have had, especially when it comes to like staff well-being, and of course leadership. I mean, I didn't really think I had any leadership skills, but I found that when I was doing the breakout rooms and things like that, I really got into my element, and like I'd be presenting on slides and on things that I had read up on, and that really helped as well. And also finally, as a writer, I am actually a journalist, and a lot of the writing I've done lately has been around trauma-informed care and the nature of trauma and why that's important in terms of the whole social context within which service users kind of go through on an everyday basis. So it's been a really great journey for me, and I think it's not without struggles. I think especially when it comes to like the systemic issues, which I feel a bit helpless to kind of be able to change, but on a small scale I do think we have made a difference to people. And if you have a look at some of the feedback we've got, someone said it was the best training I've had in ELFT. And I mean, I think that there's something about training that kind of puts people off. They kind of like look at the word training and it's like they're filled with dread. And it's kind of like, if you want to think of like the 5Fs model, they kind of want to go for the flight one, because it's just not something that they want to do. But we found that because it was quite an interactive session, there was a lot of, it wasn't just kind of us talking at people for 6 hours. It was, a lot of interaction and, asking people what they thought and asking for people's insights and sharing ideas. And I think that made it something a bit different from maybe your typical training. And yeah, like, people have said it was sensitive, insightful, and compassionate. And I think these are really, really important qualities to have in someone who is, working in mental health, including, as Elena said, admin staff. And we also opened up the training to like third sector people as well. So I think it's been really, really helpful in that sense. And then like in terms of, next steps, one of the things I mentioned was that, being one of the little people, so to speak, I felt a bit like I couldn't really change the bigger wider issues. So like to be honest, I really don't like the idea of restraining anyone. And I know that restraint and seclusion are both things that disproportionately impact people of color. But how can that be changed on a system-wide level? Because the chances are people may not be doing it consciously, but how do we address that unconscious bias that leads to more people of color being restrained and secluded? And that's just like a really big existential question that, to be honest, I'm not sure exactly what the answer is. You know, that I have the power to change. So you know, some of the things that people mentioned were kind of around you know, wanting their whole service to get the same training, and you know, sharing learning, things like putting things into practice, and also for management to understand that it's more time consuming. I think that's a big one, because, you know, I'm very familiar with how NHS is so often, you know, understaffed, overworked, you know, to a chronic level. And it can be really, really hard to ask people to put in, you know, more effort when it comes to things that they may be burnt out or finding difficult to do already. So those kind of wider questions I really want to try and address. And if I had it my way, I'd be Prime Minister, and I would like put a whole lot more funding into the NHS, so then it wouldn't be a problem. But unfortunately, that's not going to happen anytime soon. But I do think that there is something around continuing to have these conversations, because resourcing is an issue. And like, if we're just burying our heads in the sand and pretending that it's not, then it's not going to help anyone. So I really want to encourage and continue to you know, advocate for having more funding, more resourcing, and ultimately more time for people to, you know, be able to work in a more trauma-informed environment.
I think one of the things we talked about, Mina, around this was actually about the idea of looking at how we commission services and thinking about how we can commission services in a way that's more relational, actually, that values the relationships at the heart, rather than necessarily, or as well as some of the outcomes and the ways that we already commission. Yeah,
because it's quite robotic at the moment, and it's a bit, it's a bit abstract. Absolutely. So
shall we move on to the next? Yeah, because I'm aware of time as well. I think, but you know, there's a whole host of reasons. We can skip this one because I think a lot of this has been said, of why we think that actually trauma-informed approaches really support the workforce, and a lot of it is summarised here, that actually there would be far less healthcare burden and suffering if we incorporated trauma-informed approaches. There's quite a bit of evidence here. You can see all of these papers that have already been published. There would be an improved kind of engagement and relationship to help seeking, which is kind of one of the things we really struggle with. And we talk about people as not engaging or not having insight, that kind of thing, and improved outcomes for people. And there are lots of reasons why it's a good idea for employees, for staff in the system. Some of them are listed here. And the final slide that we want to put up is really some questions, some food for thought, which is, you know, rather than the autopilot, can we be allowed to pause before we respond? Can we, you know, how can we have safe conversations amongst our teams without being kind of fearful or frightened? How can we incorporate ourselves and who we are as people into our work, rather than necessarily having this kind of personal professional divide that we might feel is necessary? And how can we recognize, you know, these responses within colleagues, within others in the system, and work through that together? And I think a lot of, you know, I suppose it's a case of perhaps sometimes thinking about what other hooks can we hang this work on, that are all, what things are already happening, and what keeps us awake at night. What problems might this solve for all of us, as, you know, as individuals, as teams, as services? Okay, I think we'll stop there because I'm quite aware of time. If you'd rather engage on Twitter, we just put our Twitter handles there.
Brilliant. Thank you, Elena and Mina. We haven't got too much time, but we might ask one question now, and then we can try and have a larger panel discussion at the end. One question that's come in is a question from Helen, which is, how do we stop the system re-traumatizing patients by rejecting referrals for services due to behaviours that are likely trauma responses, such as kind of coping behaviours like drug and alcohol use, violence, aggression, disorganised engagement? Any thoughts on that one?
Well, one way is to understand them as trauma responses and to not have them as exclusion criteria, I suppose, it is the sort of first thing I'd say. But I think if we have flexible, you know, the transformation program is about engaging with complexity and the reality of people's lives. And actually, you know, lots of our criteria for services are not necessarily engaging with that complexity, I suppose. I don't know if others might have more to say.
I guess something I'd say is that, you know, trauma-informed care and compassionate care is not about just answering yes to everybody. It's about being strong and making sure that we have a really, you know, robust responses of why we might be thinking somebody isn't appropriate for a particular service. So it's not just that it's trauma uninformed to reject a referral. It's how we do that and what we offer instead, and to have a conversation and a relationship, you know, building a relationship with people, I guess, in order to work out the best things. Because very often people would say to us, yes, we would like long-term psychotherapy for years. Well, we actually can't do that. So it's being able to offer what we can and being honest and upfront about it, and then, you know, you're much more able to reduce distress arising from rejecting referrals.
Yeah.
I think there's something about what it's like both for the referrer to refer, but also how they manage the expectations of someone being referred, what to expect, how long to wait, when will someone contact you. All of these things are the kind of things that are really hard as a patient to experience, to not be able to follow up on kind of what's happened to your referral, where are you in the queue, all of these kind of things. But I think also, I guess, in terms of a health service as a whole, working in liaison psychiatry, you know, it's more common than not to have more than one thing going on. It's more common to have something going on with your physical health and your mental health simultaneously. So if we design services that exclude people because they've got a substance misuse problem and a physical health problem and a mental health problem, then who are we really seeing? Because those people don't really exist. But anyway, that's a funding issue as well. So I'm mindful that we should break. We will break for 10 minutes and then we will be back after the break. If everyone can please join back promptly. We've got Jonathan Tomlinson and some of his colleagues and a presentation on inpatient services as well. Keep the questions coming in. We'll try and answer them in a panel discussion at the end. Okay, so I'm keen that we get started again because we still have so much exciting stuff to get through and listen to this afternoon. The next part of the session will be Dr. Jonathan Tomlinson and some experts by experience who will be joining him, Anna and Caitlin. So Dr. Tomlinson has been a GP at the Lawson practice for the last 20 years. He's a member of the London ACES Hub and a trustee for the Shoreditch Trust and Centre for Health and Public Interest. We can share a link to his blog at the end as well, which is fantastic. So I'd invite Jonathan and his colleagues to share their presentation with us now.
I lost you very briefly, Kate.
Are you? So I'm back. Are you ready to?
I'm back now. Yeah.
Fantastic. The floor is yours.
Okay. All right. I'll just. I was going to share the screen, but maybe first we should just introduce myself. I'm Jonathan Tomlinson. I'm a GP in Hackney at the Lawson practice, and I've been there for 20 years. And I'm here with Anna and Caitlin, who are my patients, but also co-presenters in trauma-informed care for GPs and GP trainees, and now mental health professionals as well. I'll let you guys introduce yourselves.
Hi, my name's Anna. I'm 20 years old. I've been in recovery for drug and alcohol addiction for 2 years now, so I'm 2 years sober. I'm currently living at the Amy Winehouse Foundation, which is supported housing for young women in recovery. And yeah, I'm very honoured to be here doing this talk with all of you today.
And quickly following from Anna, hi, I'm Caitlin, I'm 23, and I also live at the Amy Winehouse Foundation. I struggled with drinking drugs for a long time, as well as an eating disorder, and I've been in and out of mental health services for years, as well as different kinds of supported housing. And when I found out that Dr. Tomlinson was doing this, I thought it was really cool that he was getting patients involved to kind of give their voice the other side of it. And yeah, the stuff we've done so far has been really cool, so I'm looking forward to doing this today.
Thanks very much. Look, I'll share the screen. There's only 3 slides, so it's super easy and quick, and just gives everybody an idea of kind of how I think about trauma-informed care and how I think about trauma. One thing that maybe hasn't come up in the talk so far is that the problems that we see were designed to protect us. So trauma isn't, when we talk about trauma, we don't mean the stuff that happened to you when you were growing up. We rather think about the problems that you live with as a consequence of that. So it's what happens inside you as a result of what happened to you. And the physiological and behavioral responses to trauma, especially complex trauma, which may be not necessarily any particularly major event, but repeated occurrences that undermine your sense of identity and safety as you're growing up. The way you respond to that is to try to protect yourself, and your nervous system will protect you, hence the fight or flight, the shutdown, the dissociation that happens. And you will develop certain types of behavior that are designed to protect you, which involve problems with trust and relationships that you have with other people. And you become so used to living in this sort of protective state that even when your situation has changed, your body keeps behaving like that. And that's what we mean by trauma. So it's a body and a series of behaviors that were originally designed to protect you from an unsafe environment, that continue even when that environment has changed. And so in my professional practice, I would estimate that it's about 30 to 40% of all the patients that I see, and I see 30 to 40 patients a day. So it's incredibly prevalent, and I see the kind of the problems and behaviours and medical conditions that are related to that. And then the model that I use to describe what's going on with these patients is called the trauma world, and it's a hand, and it's an easy way to remember it. And I make postcards which myself and my clinicians have and sometimes use to facilitate discussions with patients. And these are the different areas. I don't want to go through it systematically because actually I'd rather hear from Caitlin and Anna, but they've seen these slides and talked about it. Are the bits there in particular which have been sort of helpful for you guys, or that kind of speak to your experience of this? I don't know. Caitlin, do you want to start?
Yeah, sure. And I think the idea of safety is really important because all of these are mechanisms to keep ourselves safe. And especially fight or flight, and it comes out in anxiety. And I remember being told quite a lot that I needed medication or antidepressants because there was an imbalance in my brain, because it was an irrational response to what was going on, but often bad things had happened before, the worst outcome had happened before, and it wasn't irrational. It was my brain's way of, it was a rational response to what was going on, basically. And the best way that I could describe fight or flight is a bit like a roller coaster. And it's the feeling when you're kind of going up and you're just about to go towards the big drop and you're holding on really tight. And you try to self-soothe while telling yourself that it's going to be okay and it's not that high. But your body is acting completely opposite, and you are shaking, your heart is beating out of control, and you're completely fixated on what's about to happen. And it means you completely ignore and feel agitated at the people that are telling you to just relax, because it's not that simple. You know, you're telling yourself to relax, but you can't, because your body is acting in such a way that it's saying, if you see the danger everywhere, you're not going to be caught out. And it's completely, hyperarousal in my world is completely paralleled with dissociation, because it's a complete shutdown. Yeah, Anna, what do you think about hyperarousal or fight or flight?
Yeah, I think for me, I relate to all of the things on the trauma world hand. I think for me, like, hyperarousal and all that, it's very much about being also like very sensitive and very hyper aware of others perceiving perhaps like negative judgments, in particular, everything having such a almost inappropriate internal reaction to what response a situation may call for, like may seemingly rationally call for. And I think that the one on here which has affected me the most in terms of healing from trauma and recovering has been toxic shame, which is very different to normal shame. I see there's been two sorts of shame, one which sort of reminds us that we're these imperfect beings and it's almost felt more like an embarrassment, and then toxic shame, which is this impending sense that I've done something wrong or I am inherently wrong. And it's just like an inappropriate reaction in magnitude, again, of a response to what a situation would call for.
And also for me, I think guilt is what I did was bad, but shame is I am bad. And I've come to realize that a lot of my past events were rooted in power, and I felt completely powerless. And if everyone is telling you that you are ill or bad, then you have a deep sense of difference from everyone else and a complete disconnect from people. And this propels this sense of shame that there is actually something wrong with you, and that everything that has happened or that is happening is because you deserve it. And I think you really lose your voice within that, because you lose all sense of reality. It's all, I am deserving of only this badness. And I also think when it comes to dissociation, that's quite a prominent one, because I remember when I was first learning about trauma and someone asked me, you know, do you dissociate? And I said, no, when there's, you know, traumatic situations, I actually feel myself calming down. But after I left that conversation about trauma and its effects, I felt completely knackered and tired and completely unpresent. And it was like a big fog had hit. And internally, while I was talking about it, my brain went right back to all those places and past events without me even realizing it. And it became clear that my brain was sheltering me from the outside world. And it's like the internal version of hiding, because you can't see the danger because you're just not present. And you start to wonder why you're so tired and your brain isn't making links to all the triggers. And in that moment, you're making shaming, internalized thoughts of why I can't motivate myself. Why am I so lazy? Why can't I socialize right now? And it's hard to snap out of that and realize what's happening to you when you're in it.
Are you able to talk about how kind of coping fits with that, given the experience of toxic shame and fight or flight and dissociation? What kind of manifests as coping for you both? Maybe Anna.
Yeah, so my way of coping was to numb out from the world via substances, via all different sorts of addictions, actually. I think before, when I was a child, or like when I was a young teenager, this actually came about through having like obsessions. So, you know, maybe being obsessed with like a celebrity or being obsessed with a person, and then using that focal point as a way to avoid the rest of reality, as a way to deny what was actually happening. And then as I got older, that went to substance abuse, which, looking back, I have total understanding why I chose, you know, and if I was, you know, 14 or 15 again, I'm sure again I would start abusing drugs and alcohol, because it felt like what I was doing to myself was I was actually managing my emotions and managing the difficult reality I was experiencing. And it wasn't like I was doing it because I wanted to help myself. You know, I wanted to stop the painful emotions and thoughts from happening, and it could give me a control over myself and over who I was and what I was feeling, which was a lack of control. And that sense of powerlessness which Caitlin was talking about was definitely one of the most prominent parts of growing up in an abusive family, and trying to then find ways in which I could pull back some sort of control over my situation.
And Caitlin, what did coping look like for you?
I think again, like, it was safety. Like, I knew if I stopped eating, then all I would think about was food, and I wouldn't have to think about what was happening around me. And if I was drinking or if I was using, I was calmer, or my thoughts in my head would stop. And why would I stop if I didn't feel safe in the world sober? And my coping strategy wasn't always drugs. I would sleep, I would play Candy Crush, I would watch TV, and I wasn't so dominated by life when I did those things, and I could allow bad things to happen without not being present. And I think the scariest thing about coping is when your strategy stops working, because that the way that I see addictive behavior is a mechanism to slot into normal life. And when they stop working, it's terrifying. But all of this stuff is self-medication to be able to work out how to do life, or to be able to do life in a way that makes you feel like you're not going crazy, or everything is not so overwhelming to you. And for me, that was all of those things.
Yeah, it's the second time you've reminded me that both of you that actually I'd previously assumed that kind of taking drugs was a way of sort of escaping, but actually you reminded me it's a way of kind of being normal, because the alternative is kind of not real. Like the being on drugs is more real than living in the trauma world.
Definitely. I mean, I thought drugs was the solution, you know, I thought that was what.
Yeah. Anna, have you can you hear us? Are you still there? I think you might have frozen briefly.
Yeah, her computer's having a bit of issues.
Oh, no.
She'll be back.
She'll be back. I mean, now we're beginning to move on to kind of coping, and then thinking about kind of coping in other healthier ways. Flip side, and at the social security. Caitlin, do you want to talk about Amy's place?
Yeah, of course. So Amy's place is a place for young women. There's room for 16 people, and you stay here for 2 years. And it's really interesting because when a lot of people leave rehab or leave supported housing or are given medication and go right back to, they're going right back to the place in which everything bad happened. So nothing is really going to change. And the thing about Amy's place, it is taking you out of the bad environment completely and putting you in a place which is completely safe. And it's the power of Me Too. There are women that are all in the same position, just trying to get better. And what I love about this healing hand, which I think is so important, and I've spoken to my parents about it, I've spoken to so many people about it, is that social security is on the thumb. And Jonathan always gives this demonstration of the thumb overpins everything. So the human relationships, the biology, the body and the mind, none of them are possible if you don't feel safe. And every time I went back to the doctors and I said, I don't think my dose is working for antidepressants, they would just increase it. And I didn't feel safe and I didn't have any human connection. And I was given these drugs, but nothing else in my life was changing. So I think it's a really good visual representation that the healing world is so complex and that biology is only kind of a fraction of that. I'm not sure if this is my internet or...
It looks like Jonathan's having some technical issues as well.
Uh-oh.
But I'm wondering, Caitlin, are there other aspects of the... Oh, we've lost the slides. I can probably share them. If there are other aspects of... I think Anna's back now as well, so that's good. Are there other aspects of healing, Anna, that you can talk about? Perhaps we got on to talking about the healing world with the hand and the social security and relationships and so on. I'll try and find the slides and share them from here.
Yeah, definitely. Apologies about that. My laptop crashed. I think for me, the biggest thing, the most fundamental part of my recovery from trauma has been through the relationships I've formed, through the trusting relationships in which I have people now in my life who can see the best in me and who've believed in me even when I couldn't believe in myself. And I think, you know, over time, the thing which these relationships need is space and time. And I do believe that both GPs and psychiatrists can provide that through these sorts of long-term relationships.
And I also think that it's an incredibly hard job for GPs, because obviously not everyone has an Amy's Place. In fact, hardly anyone does. There's only 16 of us, and you have 10-minute consultations, and it's all very quick, and it's quite hard to know how to help. But the most impactful moments for me when I was amongst chaos was when I was really emotional and I was sitting in the consultation, and my pain was being acknowledged. I was being looked at, and this one GP in particular would say, I can see you're in a lot of pain right now. What's going on? Instead of other consultations I've had where they've just told me to get a blood test, then have a medical examination, you know? So I think that human on human conversation and contact is so possible in those small consultations, as well as consistency and seeing the same person, and for them to ring you up in 2 weeks just to check in and say, how's it all going, you know?
Yeah, absolutely. And I think as well for me, I'm very fortunate actually being able to identify as an addict, because this means that I have meetings all over the country and support groups in which I can find a community of fellow people who are trying to overcome the same sorts of problems I have faced. And I would say that, signposting to support groups, you know, that's another great thing which can give people that like human to human connection and support that we need if we are going to be able to face the pain that comes with recovery.
And also it massively goes down to expectation, because being given the diagnosis of BPD or that in particular is so damaging, because it says that there is something diagnosably and visibly wrong with your personality, and often these diagnoses are quite quickly come to, you know, and that can be quite detrimental to someone, because when does BPD stop? When do you stop having borderline personality disorder? And a person that doesn't expect to get better will try less, and hope is such an instrumental part of that. It's allowing someone to have the hope to expect to get better, you know, because when someone expects to get better, they're likely to be more proactive and trying different avenues. But the rapport needs to be built up, and that does happen over time, because opening yourself up quite quickly is, from question after question, you are opening a box of trauma, which can often leave people feeling more vulnerable after the consultation than before, because they don't know how to close it. You know, they're on the referral list, or they don't have spaces in which they can talk. And so holding what people are saying and being kind with it, treating their pain like it is hard for them to say, is so important. And that's all the human on human kind of interaction.
Can I ask you an important, difficult and quite common question, which is, how important is it for your GP or healthcare professional to know what happened? I know Mina suggested that we should move from what's wrong with you to what happened to you. What do you think?
I think it's quite a difficult question to answer, because I guess everyone's going to present differently in what they need from a session. I think what I sort of have found most useful in my own recovery from trauma has actually been it's been understanding how these traumas are now affecting my present life today, and trying to find ways of dealing with that and managing that. I did this, I'm doing this amazing book by Pia Melody called Facing Codependency, which I recommend to everyone listening to this. And it's sort of, for me, that book identified all the different behaviours which I thought was which I thought was just who I was, and it turns out actually no, these are effects of trauma. And because I could see them then as effects, it meant that it was so liberating, because I realized that again, like, it wasn't something that was wrong with me. These were symptoms or effects which I could then work out how I could heal them and stop them from preventing me from living the fulfilling life that I always wanted to live.
And from what Anna was talking about, education is so important, and obviously GPs need to know this information, but it's all about eye contact and how you respond and how you ask. If you're just going and then in saying stuff like that must have been so tricky, and there's no acknowledgement of the pain that the patient has just said, then it becomes quite an exposing, vulnerable thing. Whereas if someone is saying, hearing you and seeing you right in front of you as a human being there, instead of a patient, as you mentioned before in this presentation, the power dynamic that can often be there, it's so, when there's kindness there and when it's a reciprocal thing, and where it's not just staring at the computer and going from possible diagnosis to different questions, it's that acknowledgement, I think, is how you can do that in a kinder, more sensitive way.
Oh, absolutely. And I feel like it's less a matter of what language is used, but more one of intention. And so if someone has the intention for another to feel safe, helpable and understood, then I believe this is enough, regardless even of how the other responds, because we can't control the reaction of another, only our best and sincerest of intentions.
I don't think I can add anything. You're so beautifully, brilliantly articulate, and have said everything I want to say, but just much better. We've kind of run out of our time for our slot, I think, and I don't want to intrude on anybody else, but I do want to leave time for kind of questions. So maybe Cate, what do you think?
Thanks, Jonathan. And sorry, I took over screen sharing, but
yeah, I got thrown off.
So I think we've got a number of questions, but I wonder if we do, I mean, one that I think might be useful for the whole panel to ask is about the question related to kind of personality disorders. And I would actually like to invite all the panel on to discuss that at the very end, because I think it keeps coming up and I think it's so important. Lots of really positive comments for Caitlin and Anna, and thanks in the chat, which I'm sure you'll see later. So I wonder if we do move to the next presentation, and then we can try and all come back together for a discussion at the end, if that's okay. So I'll just finish I'll stop screen sharing now. And we'll move to our next presentation. So we've got Ryan and Navi, and I'll just introduce you. So we're going to be talking now about the strategy and implementation of trauma-informed practice in inpatient settings. So Ryan is a clinical psychologist specializing in adult mental health. He's currently the co-lead for locality psychology in Tower Hamlets and is leading on the implementation of trauma-informed practice in Tower Hamlets Centre for Mental Health. And Dr. Navi is a clinical psychologist specializing in aging-related mental health and dementia diagnosis and support. She's currently working in older adult community and inpatient services. Outside of this, she's also the older adult module convener at the University of East London, doctoral training in clinical psychology. So I will hand over to Ryan and Navi now, and please do keep your questions coming in. And thanks again to Jonathan, Anna and Caitlin, and we will convene with everybody for hopefully a longer panel discussion at the end of Ryan and Navi's presentation.
Hi everyone, just give me 1 second. Turn this into a presentation. So yeah, I'm going to go first, and I'm just going to talk a little bit about a bit of why specifically for inpatient services trauma-informed approaches are important, and then a little bit about the strategy and some of the things we've been doing in adult services, and then I'll hand over to Navi to kind of talk about how some examples of how they've been implementing some of this stuff in the older adults inpatient services as well. So I suppose, you know, just some illustrative figures, and of course, you know, there are always kind of ranges of these things, but in terms of things that service users who are inpatients in psychiatric services may have experienced, just some things to kind of set our minds for why this is important things to be thinking about. So from one study, I'll put the references up shortly, but psychiatric inpatients, and 63% of them had suffered domestic violence, specifically in the year prior to admission, which always interests me because I think it's a specific type of trauma which doesn't get hugely discussed a lot, at least on the inpatient wards where I work. 85% of inpatients had suffered childhood sexual abuse in this particular study. And also, just to highlight, in terms of male psychiatric inpatients, 85% had some form of abuse in childhood, which again I think is important, just because, you know, I think it's changing and it's getting better, but certainly historically there's been this sense of trauma being something that's perhaps been more recently discussed with kind of female service users and not so much with male service users, but I do think that's shifting. In terms of why then kind of trauma-informed practice and trauma-informed care is important in inpatient settings, as kind of was mentioned previously, I think, you know, we have to acknowledge that some of our services are traumatizing or re-traumatizing, and that's the case both for service users and for staff. So in terms of some of the ways that might happen, some of which have been mentioned, obviously for service users, we're depriving them of their liberty, we're putting them in a locked environment. People on wards experience assault, abuse, racism, sexual violence sometimes. As much as we try and avoid these things, they happen. But also part of the care, which again is often done in the best practice of people. Some of these decisions are made, but people are subject to restraint, seclusion, restricted practice, and unwanted medication as well. You know, again, under the Mental Health Act, even though we may take those decisions in what we consider to be people's best interests, I think everyone who's worked in inpatients will be familiar with those conversations and how distressing it is for people who don't want to take the medication and when it's kind of having to be forced on them. And just highlighting in terms of staff then, so again, frequent assault, abuse, racism, sexual violence, vicarious trauma, by which I mean trauma that arises from being in close contact with other people's traumas, hearing their stories, feeling the emotions, potentially becoming overwhelmed by seeing the traumas that other people have been through. Moral injury, which I'm guessing people will also have some familiarity with, but you know, moral injury kind of loosely defined as being when people, because of their profession or because of the work they're doing, having to act in ways or observing practice which goes against our own kind of morals or ethics. So again, I'm kind of including restraint and seclusion and restricted practice in that, because from conversations I have with staff in kind of reflective practice sessions, these are some of the things that come up again and again, that, you know, as much as it's seen as necessary sometimes in order to keep everyone safe, staff on the whole can also be traumatized by restraining people because they don't want to do it and locking people in seclusion for days on end. And also just to highlight in terms of staff as well, this idea of emotional labor, which again, you know, can have different definitions, but broadly speaking, having to present a certain emotional face at work, having to kind of, you know, suppress your anger or suppress your grief or your sadness in order to kind of present a work face, and that takes its toll as well. And these are some of the things that are associated with kind of burnout as well. So I just want to talk briefly about strategy in terms of implementing trauma-informed practice into our hamlets, and I won't go too deeply into this slide, but just to say we're kind of loosely running off the model, or kind of in some ways mirroring the model in NHS Scotland, which is that, you know, in terms of the training, all staff would have access to the kind of training that was talked about earlier. So the kind of awareness level of trauma training, but then there are also these other levels in terms of skilling people up, helping them to learn skills which can help traumatize people. And I think in inpatient services, it does kind of overlap quite, you know, this kind of trauma-informed practice, but also trauma-specific practices, how we can help people to kind of regulate their emotions and learn techniques. And I'll come on to that a little bit more in how we're approaching that shortly. Just to say as well, in terms of mental health settings in London, there is something called the Safety and Mental Health Settings Project, SIMS, which I know of at least 2 other kind of schemes using the SIMS acronym of some form, so it's confusing. So this one is Safety and Mental Health Settings, but this is provided by a kind of pan-London group of trusts and thinking about how we can implement trauma-informed practice in acute and PQ services across London. And specifically at the moment, they're providing something called Lead Safely training, which is for managers and matrons to kind of learn all of how to implement some of these principles of trauma-informed care, thinking about kind of compassionate care, but also something called the See, Think, Act program, which some people may have heard of, which is about using relationships to improve safety within kind of secure settings. So in terms of the stuff we've been doing around staff training in Tower Hamlets on the inpatient side, we have a staff induction, and we have a whole day on trauma-informed care that's embedded now. So that's offered every 2 to 3 months. So all new staff coming through have access to that. And that is a kind of adapted version of what Elena and Mina were talking about earlier. So it specifically uses some inpatient examples, but really it's the kind of overview of trauma-informed care. As I say, kind of we've recently gained some access to some of those trainings from the Safety and Mental Health Settings program. From a psychology point of view, we kind of offer some specific away day training sessions for existing teams, and those can be adapted. So we've done ones on kind of the links between trauma and self-harm behaviour when wards are kind of struggling to kind of help to support people who have a lot of kind of self-harm going on in their presentation. There is human rights training embedded as part of the kind of Band 6 nurse development program, and I'm hoping we can kind of find ways to reintroduce that and expand it out to more stuff as well, because I think the links between human rights and trauma-informed care, particularly on the inpatient environment, are, you know, there are lots of them. There's a huge overlap. It's actually, as a brief aside, there's a good paper from a program that came out of Sweden, I think, where they did joint human rights training sessions for staff and service users all together, and massively reduced the amount of restricted practice used. So I'm gonna kind of try and look into that and see if we can pull on some of that as well. And there's also, I'll talk a bit about the what we call the safety bundle in a moment, but we're also kind of doing some webinars upcoming that all ELFT staff will have access to around kind of safety in inpatient settings, and we're going to be doing some stuff around trauma-informed care as part of that. I suppose broadly as well, there is this plan that based on that kind of NHS Scotland model, we'll move on to something more, another level of training, more skills-based training for people who are interested as well. But we're still in the kind of planning stages of that. So in terms of just thinking briefly then about some of the existing trauma-informed practice, and this is an area, you know, where it becomes an interesting debate, because of course there is lots of work which could fall under the banner of kind of being trauma-informed, lots of stuff that's gone on already. But just a brief overview. So of course we have this kind of therapeutic group program across the wards, which help with some of those, or hopefully help with some of those issues of kind of reconnection, self-awareness, and you know, I would also kind of, I'm a psychologist, but I think I would really highlight the importance of arts therapies, or anything that's more kind of experiential or body focused or movement focused, and how important that is in terms of kind of that sense of reconnecting with the body in terms of a kind of trauma recovery model. So it's, you know, certainly on inpatient settings, there are many people who can't access or can't make use of the kind of talking therapies available, which is fine. So we really do need to have this kind of range of things which helps people kind of be comfortable in their own bodies and reconnect with others as well. We've done some work, particularly on the PQs in Tower Hamlets, around kind of trauma formulation. And, you know, again, in relation to the question that came up, I found that particularly helpful in terms of people with a kind of personality disorder diagnosis, in terms of reformulating in terms of trauma. I'll talk about sensory care planning briefly in a little minute. The safety bundle was kind of work that was done, it was nursing led, and it was an MDT approach, and it kind of slightly came before the kind of trauma informed language, but really with this explicit focus on safety, improving the safety for service users and staff, which of course is one of the key principles of trauma informed care. So this was about having safety huddles, recording numbers of incidents, finding spaces for staff and service users to discuss what was happening on wards and how safe they were and how that safety could be improved. So that work was started, it kind of dropped off a bit, and it's being relaunched now in terms of kind of trainings and webinars and things. So keep an eye out if you're interested in those parts and you're on inpatient settings. We offer reflective practice for staff on every ward. We've also kind of introduced got rid of the old debrief model and put in place more of a post-incident support model where we consult with teams about what's happening. And it's really an acknowledgement that it's not just, of course, when there's a major incident that happens on a ward, but actually the kind of, if a ward is at a high level of stress for a long period of time, that can be equally traumatizing for the staff involved as well. So how can we support kind of and offer kind of, yes, something to staff to kind of acknowledge that and help them reflect on what's going on for them. And we've been doing kind of specific staff wellbeing away days, not really thinking about specific incidents that happen on wards, but thinking more about that well-being in terms of how people are individually, but also how they're functioning as a team. So I just wanted to talk a little bit about one example of what we've been trying to do, which is what we're calling a kind of sensory de-escalation strategy. So this has the aim of kind of reducing violence and aggression and restricted practice on wards, and it's based around a mixture of kind of trauma theory and sensory integration theory. So in terms of the development of it, it's been a kind of joint venture between psychology and occupational therapy, and it's largely based on these kind of two concepts coming from those theories of the window of tolerance and the sensory ladder. So some of you may have seen the window of tolerance before, and really it's another way of representing or kind of showing some of that stuff we spoke about before in terms of survival mechanisms. So the idea that we have a window of tolerance where things might be stressful, but we can, you know, generally cope with what's thrown at us. But then we have these other kind of spaces that we can be tipped into, which are a bit beyond our control. So the hyperarousal, so the kind of generally the fight or flight, the angry out of control type responses that people kind of are not in control of, but which take over. And then also at the bottom, the kind of hypoarousal, so more the dissociation, spaced out, zoned out, kind of lying down in your room all day. And really the strategy we're working on is an acknowledgement that these are, you know, not just kind of psychological states, but they're embodied states as well. And they really map onto a lot of the work that OTs do around kind of sensory integration. So how much people are aware of their bodies, both what happens in their external senses, but also what's happening inside their bodies, and also how they're affected by an environment, how they can be overwhelmed by an environment. So what we've done really is we've developed a staff training package and some protocols for teaching staff how to use sensory rooms in a trauma-informed way, but also developed a form of kind of care planning based around what's called a sensory thermometer or sensory ladder, which is basically saying, you know, when I'm working with the service user to say, okay, so when I'm in my window of tolerance, this is what is helpful for me and can help keep me there. But when I'm hyper aroused, or when I'm, you know, in this particular state, this is what will help me. This is what really won't help me. This is what I might be able to do to kind of help myself or learn to do. And this is what other people can do to help bring me back to my window of tolerance. and the same for the bottom. So it's a very simple kind of color-coded intuitive care plan that can be jointly done with kind of staff and service users, and to really focus on this idea of, yeah, when people are in these different kind of spaces and zones and having these different reactions. So that's kind of some of the work we've been doing and that we're trying to introduce. There's lots more work to be done on the inpatient side. We do have some peer support. I would like to really increase that. I think that's massively important, as well as more kind of user involvement is going to be important as we go forward as well. You know, so in terms of introducing these trauma-informed practice and trauma-informed care strategies, it can be a long, slow process, but you know, we get there bit by bit. So yeah, that's just a kind of overview of where we are in adult services and some of the work we've been doing. So I'll hand over to Navi. I can do your slides, Navi. Just tell me when.
Thank you. I'll do the Chris Whitty next slide, please, Ryan, if that's okay. Yeah, thank you, Ryan. That was really, really interesting. And I think, again, sort of working in older adult inpatient settings and community settings, it is about kind of all the levels that kind of trauma plays. So thinking about this wider staff culture and what staff are going through, but also right down to the bodily experience of it, which has kind of been covered a lot today as well. So it's really good to hear. I kind of wanted to spend a bit of time to think about the aging process, and also when sort of there's cognitive changes. It also is important to see how trauma-informed care can be transferred to different populations and different experiences. So what we can think about as you kind of move through different places that you work or people that you meet. So I just wanted to cover kind of, yeah, what it means to be older, what it means to be kind of deemed less cognitively able, and on top of that kind of being in an inpatient setting. So a lot to cover in a very short space of time. So I would likely not do any of it too much justice. So I really encourage people to go away and kind of do some further reading and research that I kind of mentioned in this bit of my presentation. Next slide, please. No, thank you. Before I kind of get started, I thought when thinking about trauma, it's really important to think about power. One cannot exist without the other. In a lot of ways, power kind of operates in everywhere. So on my left, on the screen, is sort of John Burnham's social graces. When kind of entering a room with a client, a colleague, another human being, we're all kind of carrying around these differences. They all kind of play out visibly, kind of how we look in terms of our skin color, our gender, and all these various visible ways. Also those not so visible kind of differences. All these differences are kind of important to hold on to, because what they actually mean is they kind of carry very specific trauma sometimes, as well as strengths. Which is what the image on the right shows, what's happening underneath the surface. So thinking about kind of race, the kind of past experiences or current experiences of inequality, of feeling disempowered, they're all kind of walking with us in some shape or form. And then I just wanted to focus today on aging, but in reality, a lot of our identities are on intersections. So it's about kind of trying to understand the person and ourselves, and how our race and how our privilege and power kind of play out in our interactions. So if you press next. Can people hear me okay? Okay. So again, sort of thinking about kind of the positioning of being older in society, a quick caveat is what's deemed older or old adult or older adult or older person is sometimes a bit arbitrary. In NHS services, it's kind of deemed as someone who's age 65 and plus. But actually, sometimes aging is within a process. So we all age every day by a day. And then we got to think about actually what it means as kind of things start to change, or we start experiencing things that kind of are more likely to happen the older we are. So those experiences and thinking about them in a kind of more trauma-informed kind of perspective is kind of where it's important to think about for older people. So just starting at the top there, it's important to think about kind of how they're positioned in society. So there are some headlines. So our needy elderly first. again, how's that positioning kind of being older? You often see pictures of kind of withered hands or kind of autumn leaves and these sorts of ideas. And I think actually, if I was seeing myself and these images, how relatable are they, and what kind of do they make me think about in terms of myself? This image of a gentleman with bits of his head kind of disappearing is often really common in sort of dementia literature, and luckily there's DEEP, this kind of advocacy group, who have really called this out and kind of said, actually, these aren't the images we want to be associated with, yet they exist. But all these images and all these kind of narratives, they all kind of come from a wider societal positioning of, and Stephen Post says it nicely, clarity of mind and economic productivity determine the value of human life. So thinking about actually, why are these images or narratives start suddenly coming up a lot more the older you get, and has it got something to do with how much economically viable you are, or as Preeti Patel says, economically active? So what's the impact of all these larger narratives? So I often see it kind of trickling down to actually then how people treat each other. So if people start treating you a bit differently, maybe speaking over you a bit more, or assuming things about you when they don't know you, these sort of things start to play out, and often quite unconscious. But it's important to name it, because if you make something unconscious conscious, you're more likely to understand or have some self-awareness of kind of how you interact with somebody. Carl Jung often says, if you keep your unconscious, then you're just going to think, it's going to direct you, and you're going to think it's normal or fate. But in reality, it's not. It's something else going on. And eventually those interactions and also trickle in to how someone feels about themselves. So getting these wider stories, as well as kind of then maybe being confirmed by how their nearest, dearest, or people on the street may treat them. So often, or Levy's quote there, stereotype embodiment, that kind of level of it trickling down, and how we see ourselves and our identity from exposure throughout life can kind of be created in that. But kind of other older adult specific kind of experiences is, this exposure to different types of disempowerment, like I mentioned, being spoken over, being seen as lesser than in different settings. And also the bodily changes. So thinking about kind of, if we're aging and there's something happening in our body and we're not having as much control of it, are there other past experiences or traumas that someone's had that's then kind of being reenacted in this, or not having control of your body, something not feeling right and feeling out of control? And then in linked to that, if you're then being exposed to further kind of services, NHS services, sort of doing invasive procedures, or doing kind of different names, different kind of different systems you now kind of have to get exposed to and used to. Again, it kind of brings in that another kind of reenactment. And finally, there might be some protective factors or coping strategies that we kind of had before, but then they may change over time. So a clear example is loss of kind of our social network, if through death or bereavement, who's always kind of been our support up to that point. It can suddenly feel like I have to adjust. And it's not really helped by society's kind of assumptions that the older you get, that those kind of stereotypes of can't teach an old dog new tricks, etc. It's not particularly true, but it's definitely internalized. And then how does someone feel about themselves and their self-confidence for change? Sorry. Next slide, please. But I thought it's important to kind of put these big ideas into a case. And in particular, I wanted to bring in another realm, which is a neurodegenerative condition such as dementia. Another caveat, dementia isn't exclusive to someone who's older. It can happen at any age, and vice versa. If you're getting older, doesn't necessarily mean that there's dementia kind of on the horizon. So they're kind of very separate, but obviously there's links as well in terms of risk factors. So the case of Miss A was a lady on the ward I currently work at. CA is a 61-year-old woman originally from Nigeria, first-generation immigrant. She had a diagnosis of young onset Alzheimer's disease. Her life history is that, from kind of what we gathered and what we knew so far, is that she was from an affluent family back home, and after completing her bachelor's in science, traveled the world. She married, but the relationship became abusive, so she fled the country with her 3 children. She does not have the right to stay in the UK and moved around a lot. She worked various roles and earned money where possible. She was diagnosed with dementia in her late 50s. And then she came to our ward a few years later. After diagnosis and several evictions and or leaving temporary accommodation, Miss A was placed in a care home where she lived for about 6 months. Her behaviours became difficult to manage, and they included wanting to leave, accusing staff of wanting to harm her, barricading herself in her room and breaking the windows to get out, often voicing certain things such as, "Where are my children? I don't trust you, and they are coming after me, you have to believe me." So I'll just let that sit for a moment, and just to think about what this lady's currently experiencing. So regardless of diagnoses or the current kind of lead up to where she is now, it's about where is she at this point in time, and what could she be going to at a bodily level as well as kind of an environmental level. So going from place to place, going from an unfamiliar environment to even more unfamiliar environments, those kind of moves, and also kind of trust and relationships, and what things she values and her protective factors that are missing in this kind of current situation. Okay, next slide, please. So what to kind of is the best thing to do in these situations? There are kind of one way or another, you cannot kind of overcome the fact that a relationship is one of the most important factors in any kind of practice, and trauma-informed care really kind of protects that. I'm sure people here have taken a history, and often we think about history as thinking about kind of their health, thinking about kind of the trajectory of their distress, these sort of situations, and you know, and thinking that's kind of their most important information. But actually, if you think about it in a trauma-informed lens, you think actually it's about understanding where that person is coming from and kind of what's important to them, as well as thinking kind of a bit more this notion and speaking especially about older people. Living a longer life means exposure possibly to various traumas, but also the strength to manage them, to kind of show resilience and show an ability to come together, or to kind of what things help them get through. And that's the ear that you should be listening with. So starting with kind of birth to where Miss A is now, you know, she spoke a lot about growing up in a busy household and having fresh fruit. So for me, I brought up the fact of soothing, of familiarity, grandmother being safety. Universities where I loved my studies, again, thinking about identity, thinking about kind of the things that gave purpose and familiarity. I had to protect my children. So the children who are missing in this kind of ward are really important. So how are we not considering, how are we including them in this process? How are we kind of making her remember them, or you know, honor their kind of their relationship? And then finally kind of thinking about, you know, people said they had my best interest at hand, but I've been betrayed in the past. So again, understanding why would she trust us, these strangers who claim to be healthcare professionals, but you know, who knows who we are. So again, we have to kind of earn that trust. We can't expect it. And then finally, I think that's what kind of she voiced at the end. How do I know that I can trust you? And I think that's where the relationship is key. So in terms of anything else, this quote is one thing that I've always sort of carried with me, is by David Denborough, who's a narrative therapist. He said, "No person or community is a passive recipient of trauma. Regardless of the nature of the trauma, people always respond in some way." So that's where we're listening for. That's where we're coming from, in the sense of actually, you know, the collaboration, the empowerment, that's where TIC, trauma-informed care, kind of comes in and kind of bolsters that and honors that, as opposed to just focusing on what's wrong with you kind of quote. Just overall, I think it's important to, if you have time to look at the UN's kind of principles of older adults human rights, is thinking about kind of respect, inclusivity, and I think Ryan and Mike mentioned the kind of parallels between human rights and trauma-informed care, and absolutely, you can't have one without the other. Again, thinking about power, thinking about rights, and thinking about advocacy, because working in older adults, there's a lot of advocacy, and thinking about ageism and various other kind of inequalities. That's all from me. I'll hand it back to Ryan if there's anything you wanted to add.
No, I don't think so. I will stop sharing and we can maybe come back to Cate for Q&A.
Thank you so much, Navi and Ryan. Really great to hear about what's going on our inpatient units, and very pleased as an old age psychiatrist to be able to think about older people as well, because I guess what I would say is that there is no time in anyone's life where their early life doesn't matter and doesn't affect how they experience care. And even people who have kind of processed their trauma to some degree will sometimes experience kind of a resurgence of re-traumatization at times of vulnerability and ill health. And the things that we often do on wards, which are very much kind of basic acts of care, like personal care, can be very, very stressful for people. So formulating and understanding and piecing together is so important. So thank you for that. So we've got loads of questions. I'd invite all of our speakers to put their cameras back on now if they would like to, because we've got quite a few questions which I'd like to kind of throw out to the group. I think probably the most burning one, which has come up kind of in a number of different forms, is thinking about the diagnosis of personality disorder. Thinking about kind of whether it misses the impact of early life trauma and attachment, and also thinking about what kind of Anna and Caitlin have spoken about, and also what Mina has spoken about in terms of what effect does that have on kind of internalizing the blame of external events on someone, and how that might kind of create further shame and so on. So I'd invite anyone to kind of jump in at this point and kind of share your thoughts on this.
May I jump in?
Absolutely.
So I think I have quite a radical opinion when it comes to personality disorders and trauma, and that is that I do feel like, for me, I was also diagnosed with BPD, and I'm sure if I'd stayed as I was for another 5 or 6 years, I may have even gotten a diagnosis of narcissism because of my deep fear of vulnerability and over-the-top delusions and willingness to lie, which was all out of fear, and it was all out of trauma and codependency. And I feel like a lot of perhaps these diagnoses are actually they come from these core problems at heart, which at least was definitely true in my case.
I think for me, I'm just thinking about all the people that I've seen over the years. Have I ever met a person with a diagnosis of personality disorder without trauma responses, without some traumatic events, adverse events being part of that picture? No, I cannot think of a single person. So I suppose understanding it from a more of a kind of attachment, like a developmental trauma, attachment difficulties, complex trauma, complex PTSD, even if you want a diagnosis, if you want to use a diagnostic framework, probably complex PTSD is a more helpful one for most people. That's kind of where I come at it. I know that there have been some other responses in the Q&A to that as well.
Just jump in as well. Sorry, go ahead.
No, you go, Mina.
Yeah, so I mean, I have this diagnosis. I got it after maybe 2 sessions with my psychiatrist, and then after another session he discharged me. So I didn't really get a whole lot of support for it anyway. But like sometimes I kind of say, and it's this thing that I know a lot of people with BPD diagnoses say, it's kind of like when you have a strong response to something, you're just like, oh, it's my BPD kind of thing. And that's because a lot of clinical professionals do exactly the same thing. They say she's being difficult because of her PD, she's a PD patient, she is difficult, or whatever it is. And so I think that's internalized a lot of the time. So I would say like that's kind of why I don't really like the diagnosis, and I don't think it's necessarily it should be a diagnosis when it's kind of how I respond to things that is done in a way like sometimes I I say something and I'm like, oh, that's just my BPD. And then my friends would tell me, no, actually, Mina, that's a normal response to it. I expect you to be angry about this or annoyed about this or upset. So I think it's about normalizing the fact that not everyone has like a strong handle on their emotions, and everyone is human. Because that's kind of what is implied with this PD diagnosis, that there's a disorder in mind. So yeah.
I think we've got a couple of other hands up, and I think you're definitely sort of articulating something about what happens once a diagnosis is in place as well, to the value of that person's testimony and what they report. So that's something to consider as well, and something about the transparency about how diagnoses are given as well. But I'll hand over to Marion first, and then Navi has something to. Oh, you're just on mute, Marion.
God, how long have we been on Zoom? And I'm still doing that. My entire working career has been working with people who have received a diagnosis of personality disorder. And those of you who recognise me from previous jobs, I know I've seen some of you in the participant list will know that I'm quite radical about this. But what I really think is we should ask the people who are receiving these diagnoses what they think, because I have met people who say, thank God I've now got a label. Thank God I've now got something that gives me connection with other people who are experiencing a similar thing. And they want to be labelled with that diagnosis. And also it means that they can get access to services. So for example, some of our services, you cannot be treated. You can't receive therapy unless you accept that you have borderline personality disorder. And personally, I think, there's so much research evidence that does not support a structural, there's no sort of proper structure to personality disorder diagnosis. There's no agreement, it's very, very weak. And I think we should get rid of the whole concept of it. But the structure of the NHS is such that we need to work within it, and we have to be in it to change it. And that's just my viewpoint. I wouldn't want the diagnosis myself, but I would want therapy, and I would want access to therapy and treatment. So I think it's a lot more nuanced than that. But yeah, I've never met somebody that hadn't experienced adverse experiences in their childhood or development. And sometimes it's more it's not as obvious, so it might be neglect, it might be emotional neglect. Somebody might present very materially looked after and cared for, but actually their emotional upbringing experience and their attachments are extremely damaged, and that has given rise to these manifestations that lead to the borderline of neurosis and psychosis diagnosis. Navi.
Yeah, I think the only thing I would add to kind of what's been said so far is this. I'm always worried about the idea of neutrality around it. This idea that it's a diagnosis, it's fact, and I think what we've said so far is actually no, it's all a bit questionable at times. And there's a great paper by Mary Boyle called "Making the World Go Away," and how kind of psy professions like psychiatry and psychology really benefit from the label personality disorder, because what it does is it kind of protects the transfers of trauma. Because if you're thinking about actually past traumas can have an impact and kind of our existence, our distress levels, our tolerance, then as a healthcare professional, the all-knowing, how does that feel to have that kind of, to hear people's stories and then to sit with that? Is it safer to put it in a box and then again design services around it, because then it feels like we're managing or helping with the distress? But I think the key thing is you can't separate them. Sitting with the pain is really important, as kind of Caitlin said, but also understanding that you can't ignore the context, you can't ignore what someone's experiences are and how they're experiencing you as well. So I think it's just there's a need both ends in a way of kind of boxing and managing. but actually, yeah, it's important to be critical of these things if you feel you have the power in your voice to kind of question it, because it may be in that room you don't, but there are places outside. So there's an organisation called PD in the Bin, which kind of really strongly advocate for the critical side of that as well, and there's various others. So make connections, read around kind of the textbooks, and then then kind of just make sure that kind of falls into your practice, but also how you kind of see it yourself.
Thanks, Navi. Anna, you've got your hand up as well.
Hi. I just wanted to come in and say that I know I've been talking about this label as well, codependence, and funnily enough, the woman who came up with this melody, she regrets calling it that because, again, of this sort of label and all the connotations that surround it. But this book honestly did change my life, like breaking free from facing codependence, because you go over all the events in your childhood which were abusive and growing up, and then it takes you through a step-by-step guidance of how these are now affecting your life and your relationships and your sense of identity and your relationship with yourself and your ways of dealing with boundaries, of having mood swings, of the physical manifestations of these internal symptoms. And I think when I just wanted to say that when I've been using this term, I may not be talking about the thing which a lot of people may be thinking of. I mean this very exact sort of disease, which has like 5 clear things of it, like qualities of it, which is the one which she's talking about. That's all I wanted to say.
Thank you, Anna. And I think we've put the name of the book in the chat as well. So I know some people have already mentioned that, looking forward to the reading list that comes out of the presentation. So that's really helpful. Thank you. Lots of comments in the chat about personality disorder diagnoses and kind of questions about whether it's the name, if it's a problem in the name, or the kind of stigma that is attached to it. But I also wonder if there is something about actually just how society and professionals or humans actually respond to trauma, and how, if so many people who have attracted this or been given this diagnosis, whether they wanted it or not, have so much trauma, whether there's something about not being able to really face that, and a tendency for society to blame the survivors of trauma that is kind of manifest in that, and then the kind of feminist perspective of kind of women not having been believed for so many years as well, to add into that. But there seems to be some energy in the chat for kind of exploring this further. I wonder if anyone here has any thoughts on whether the kind of move to complex PTSD has any kind of potential in being an improvement, or is it just a different name? What do people think? Marion?
I think a quick search on Twitter will reveal a lot of what people think about complex PTSD versus BPD as a label. I mean, I think complex PTSD is a good step in the right direction, but it's still a diagnosis, isn't it? And I guess we're constrained by DSM and ICD-10 manuals and how we are funded for services, so we're constrained to diagnose. But I mean, I have to say that I can't believe we're sitting in a Barts academic afternoon talking about this. You know, this we have been talking about this for decades, and it's just wonderful to hear that, you know, we are open to discussing diagnoses and the idea that maybe it's a complex developmental presentation rather than something that we need to slap a label on. You know, this is great. And the other thing I want to say is that a really quick look on TikTok, if any of you can bear it, will reveal so many young people who are claiming the diagnosis of personality disorder and emergent personality disorder. And I see it in CAMS as well, people being diagnosed with this. And to me, that's terrifying and really worrying for the young people's future, because that label won't leave them. But if we're listening to service users, perhaps that's what they want. So again, I'll put it back to people getting the label.
Jonathan. Oh, you're on mute.
When I got interested in this area, maybe 5 years ago, and we had a series of meetings in my practice, we stopped using these labels, and I haven't heard it mentioned in my practice of 15,000 people in the middle of Hackney since then, like barely ever. If anybody who's new to the practice does mention it, then usually people who are around say, oh, what you mean? Oh, you mean trauma? And so we haven't, yeah, you'd really struggle to find personality disorder written in anybody's notes in any of our practice, in any of our patients. So things can change like that.
Thanks, Jonathan. Mina.
Yeah, and I just want to add, like, I find it very interesting that we're talking about complex PTSD and trauma, because I feel like medically speaking, trauma is quite narrowly defined, at least in kind of my research on it. You know, it doesn't include quote unquote psychosocial stresses, or it doesn't, like, it's quite a narrow definition, and that means that you know, things that may affect people in East London, for example, like which has like a really high ethnic minority population, you know, so people face like racism or homophobia or transphobia and so on and so on. And those things are not seen as kind of the automatic things that come to mind when you think of trauma. So I think part of it is also about expanding what is meant by trauma, because when we deliver trauma-informed care training, we look at trauma in a very in that quite broad sense, which I think Marion kind of touched on. And I think it's important to keep in mind the fact that there's not agreement necessarily between like clinical stuff on this topic, on kind of what counts as trauma, what doesn't count as trauma, because there are some, like I remember at a training once, someone and you know, I was talking about how, you know, during the pandemic we've kind of all gone through this like collective trauma of losing so many people because of coronavirus, and then his response was, well, I don't think it's been traumatic. And I think it's about the fact that you've got to acknowledge like what is traumatic to one person is not necessarily traumatic to another, and it's really, really specific to someone's identity. And yeah, just to keep that in mind when we think about, you know, other ways of phrasing it, because it may be that is what stops like a clinician from making the diagnosis if they don't agree that this X thing is trauma. So yeah, I think that's where it gets a bit tricky, I think. And also rebranding, I'm not sure if that's the best way to do it, but I'm also not sure what the alternative is. But I'm definitely open to suggestions for sure.
Sounds like we maybe need a whole Barts afternoon to discuss this further, but we've got many questions, but one from Delphine is about a concept of tolerance, and is there an element of kind of how this can be applied to people around the person who's experienced trauma, healthcare professionals included, and their level of tolerance towards the person's distress or their response. So if the support network is able to accept, understand, and respond with kindness to what's happened, does this make any difference to the outcome? Does anyone have any thoughts on kind of the response of the person, of the people around the person?
No, go ahead, Elena.
Well, if we think about what helps, what are the kind of key elements, I suppose, that sort of define trauma-informed responding? It's certainly things like compassion. It's certainly things like if there's a rupture in the relationship, being able to repair that. It is things like, you know, being able to recognize our own limits, and perhaps also being, you know, having to do some work on ourselves as well to actually be in the systems that we're in. And that's sort of part of why I invited people to think at the start of our talk about how does this land with you? What are the responses coming up in your own body? Trauma is embodied. we all have a response to this stuff. Adversity, trauma, much more broadly than PTSD, complex PTSD trauma. That's not what we're talking about here. We're talking about trauma responses, aren't we? Because this is everybody. This is kind of all of us in this. Because otherwise that sense of safety, using kind of language that's human experience language generally is what people like, you know, all of those things won't come across to whoever you might be working with.
I think I also did read a study about how the response to the first disclosure of a traumatic incident in women does dictate kind of whether someone will, or at least plays a part in whether someone will go on to develop depression and PTSD. So if people are believed and supported and validated very early on after a disclosure, it does affect outcomes. Navi, you say.
Damn it. I had my mic off. I just wanted to quickly bring in there about carers. So I'm thinking about the work with older people or people with a diagnosis of dementia, and then kind of carer burnout and the tolerance the window that really applies there. We talked earlier about kind of staff training, but just bringing it back to kind of carers or unpaid carers who carry a lot of responsibility and kind of emotional efforts, and then if that person they're working with is, you know, their loved one is feeling traumatized, it can transfer, but also the changes that they have to kind of adapt to. One of the things that's done in Newham MHCOP, so the community mental health team for older people, is a carers group where the main kind of focus is on kind of sort of, I guess the main aim is to reduce burnout and to think about kind of having a therapeutic space to express the very real experiences, having peer support of what it's like to kind of to now suddenly be from being someone's wife and daughter or son to now being labelled their carer and having to adjust every day. So I think the window of tolerance is one framework that's kind of used there, but I think it's mostly about kind of bringing in the idea that they have a space so they don't have to be, they can let their guard down, don't have to kind of be the strength of the family or the kind of person who holds it all together, and kind of because they have to in the house, they kind of can come away from that place. And simultaneously we're thinking of running the group for people with a diagnosis of dementia, CST, cognitive stimulation therapy, so they can do both at once. So it's just about actually if services can be designed to kind of give as opposed to ask the person to give more, if that makes sense. It can hopefully challenge that kind of burnout and the imbalance there.
Thank you. So we've almost come to the end and we've got a lot of questions still that we could answer. Perhaps we can kind of respond to them. But I guess I'd like to finish up by asking anyone who would like to, I suppose, to say kind of one final thing about what they would like to tell trainee psychiatrists, many of whom are watching here, about what would be your one, sorry, my dog's just getting off the sofa now, one final message for trainee psychiatrists if they take one take-home point.
I think just be open to learning about this stuff and going on a bit of a journey with it. If you haven't read The Body Keeps the Score, that's a really good place to start, I think. Or NHS Scotland have some really lovely, really short videos that give a good flavour. That would be my, just engaging with it. And then see what you make, see what you make of it.
We'll go to Marion and then Anna after that.
Just to say that, we're not staff versus service users, we're all service users, and that taking your whole self to work and taking off the lanyard and the name badge sometimes can be helpful, because we all may need services at some point, and that can help you be a compassionate caregiver in your future careers.
Great, thank you. Anna.
I just wanted to say that a GP or a psychiatrist, you very well may be the first port of call, which is a huge amount of responsibility. but it also means there's a huge amount of good which can be done.
Thanks, Anna. Mina, I think, is next.
Yeah, I would say, you know, if you're able to focus on one thing, I would say it would be cultural competence, especially when you have patients who, you know, may not look like you, and just being really aware of how that is entwined with trauma-informed care. And yeah, look after yourselves as well. That's a really important thing.
Thank you, Mina. We'll go to Navi and then to Caitlin. Oh, you're muted again.
Sorry. I think if you're thinking about kind of what is the best treatment or what to do, the best way to think about it is the relationship is the treatment, the relationship is the antidote, it's the relationship which you have with one another and with yourself and the person on the other side of the table or wherever you are. It can't be ignored. It's definitely kind of the one and only thing, I think, is to kind of focus on first and foremost.
Thanks, Caitlin.
Yeah, quickly just going on from what Navi just said, and I don't want to put too much pressure on GPs either, but it might be the only space that that person has to be listened to, and it might be the only space where someone is trying to understand them. So being that person that is trying to understand your patient is just so powerful, and the more effort that you put into that, I think the better the outcomes will be. And just to be kind of continuously kind, because again, you might be the only kind person in that person's life at that moment. So yeah, thank you.
Thanks, Caitlin. Ryan. Oh, you're muted as well, Ryan.
Oh, wrong one, sorry. I'd say engage wherever you can with service user groups. There are so many of them around, particularly in ELFT, co-production groups, user involvement groups. And, you know, if you can't get to the organized groups, just speak to your service users about what might improve the services, what their experiences are of them. I think that's the real way to change some of these things, is to engage in it together.
Thank you, Ryan, and lots of work happening that people can get involved in for sure. Jonathan.
Yeah, I would say, remember, you are not your trauma, and trauma is not a diagnosis. I think you should ask, with patients who you're struggling with especially, what role could trauma be playing here, and see it in that context, and hold your diagnostic labels lightly, because you may want to change your mind at a later date.
Absolutely, and I think that's a great point to finish on. I think I would add kind of educating ourselves about power and doing what we can to redress power imbalances, and that means inviting feedback in real time, asking people what it's really like to receive the care, and being able to listen to the answers and believing people when they tell us things. One really great place to start, which I think we're starting to do more of, is writing letters directly to patients rather than about them. And that's a really great thing. I wish I'd started doing that earlier in my training. So lots of reading material coming through in the chat. I think our guests and speakers will hopefully be happy to try and answer some of the questions that haven't been answered, although many of them have generously been typing furiously throughout this presentation. Thank you so much to all of our amazing speakers for today. I'm sorry we've run over, but there's just so much to say. They've been extremely generous and fantastic, and I hope it's been inspiring for many people to get more involved in what's already going on in the trust and in the local area. So thank you very much.